Again, a very warm welcome to everybody joining us from wherever you are. It is a pleasure to welcome you to this ICMLF Regional Discussion Group for Africa, the first in 2024. We are very lucky to have interpretation from Calliope interpreters. So again, a very warm welcome. So my name is Nicola. I am the Chief Executive of the International CML Foundation. And as many of you joining us are very familiar friends of the foundation, so you are aware of our work. But really our role is to improve CML outcomes around the world for patients. And we primarily do this by sharing CML expertise all around the world through both online and in-person meetings. So please continue to join us and work with us, share our meeting highlights, be involved in our clinical preceptorships, and we, with your help, will continue to improve CML patient outcomes all around the world. And again, specifically in Africa today, so many of you have already been involved in our clinical preceptorships and joined us in the regional discussion groups last year. So that is one part of our work, sharing best practice and expertise. But the other part is we have because our network is so wide, we have a global network of researchers working with us. So we are also looking at genomics and treatment-free remission. We have a program looking at pediatric treatment in lower middle-income countries and a survey of practice on hepatitis B and CML. So many reasons to join the CML Foundation. We hope that you continue to join our programs, and we look forward to talking to you soon. With that, I'm going to hand over to our moderator today, Dr. Amanda Woolley, who is going to take you through the rest of the program. Thank you for joining us.
Thank you, Nicola. Great to see so many people joining us. Thank you for being here today for our two discussion topics. We're going to be covering anticipating and managing acute TKI toxicity and adverse events, and the realities of long-term treatment, managing the chronic effects of TKIs, chronic complications, and other challenges. Before we get started, just a few housekeeping notices. So please leave your microphone switched off or on mute until you wish to speak, and then just unmute when you're going to be speaking. It's lovely if our presenters today have somebody to speak to. So if you're able to leave your camera on, if your internet connection will allow that, please do. It's nice to see people smiling and responding when you're speaking on an online meeting. If you have questions about any of the cases, please feel free to raise your hand so that we know that you want to come into the discussion, or you can use the chat function. If you need any logistical help around using Zoom at any point, please just send a message in chat to one of the hosts. That's either Nicola or myself, and we'll do our best to help you with any connection issues. And similarly, if you have any problems with the interpretation function, send a direct message using the chat function to one of the interpreters. It should say Calliope interpreter, and that's either Alexandra or Laurence. So next, it's my great pleasure just to introduce our presenters for today. So first up, we will have cases brought by Dr. Amma Anima Benneh-Akwasi Kuma from the University of Ghana Medical School and Ghana Institute of Clinical Genetics in Accra, Ghana. And responding to that will be our international expert, Dr. Valentin Garcia Gutierrez from the Universitario Ramon y Cajal in Alcala University from Madrid, Spain. Thank you for the pronunciation. Thumbs up, Valentin. I appreciate that. Amma is a consultant hematologist, director, and senior lecturer at the University of Ghana. Great friend of the foundation. She's on the foundation's African steering group. been told by Arlene she's a tour de force at meetings and discussions and is always there when we need to know something or find someone in the African nations. She's always very generous with her time, and we're very grateful to her, Amma, for joining us today. Thank you. And Valentin is a rising star in the CML field and another great friend of the foundation. He's currently chairing the development of a new module, Next Steps in CML Management, for the Knowledge Center. This is Valentin's first appearance at one of our regional discussions, but we hope it will be the first of many opportunities to learn from you, and we're very grateful to have you here. Thank you.
My pleasure.
And later, after Amma has brought her cases, we'll be hearing from Dr. Ephrem Haile from Addis Ababa University in Ethiopia. And responding to those cases will be Professor Gianantonio Rosti from the Scientific Institute for Research, Hospitalisation and Healthcare in Meldola, Italy. And some more about Ephrem and Gianantonio. Gianantonio is a giant in the CML field. He's preceded by his reputation, and it's an honor to have you joining us today, Gianantonio. Apparently, you are trying to retire, I've been told, but colleagues at the CML Foundation hope that that just means you have more time to share your knowledge and experience with us. So thank you for being here today. And we're very grateful to have Ephrem here with us, who comes highly recommended by his peers in Ethiopia. We're delighted to welcome you to the foundation today, and we're looking forward to hearing more from you and about how you manage CML in your region. So lovely to have you here. So without further ado, we'll move on to the first case, which is anticipating and managing acute TKI toxicity and adverse events. And I'd love to hand over now to Amma, if you are ready there and able to present your first case.
Thank you so much for the kind words, Amanda. A big hello to everyone. If I can start sharing, probably if we can stop sharing and then I can share my.
Yeah, that's it.
Can everybody see my slides? I'm trying to put it on.
They're just coming. Yes, we can see them, Amma. Thank you. Got them.
Okay, all right. Thank you. So it's a pleasure being here. I'm from Ghana and is in West Africa, and that's Ghana. And Ghana has 16 political regions. And Department of Hematology is housed in Kolebu Teaching Hospital, which is the largest tertiary hospital in Ghana. And at our center, we have about 6 consultant hematologists, 5 specialists, and we also have some residents in training. So we see 15 to 20 newly diagnosed CML cases annually. Median age at diagnosis is 40. We currently have over 200 patients on TKIs. The use of tyrosine kinase inhibitors in the treatment of CML has indeed changed the narrative for people living with CML. Quality of life and survival of people living with CML have significantly been impacted. Despite these achievements, the role and significance of side effects cannot be overlooked. Each individual reacts to drugs differently. Fortunately, not everyone experiences an adverse reaction. Others experience it early in treatment, others later. Some common acute side effects of TKI include nausea and vomiting, diarrhea, muscle pain, cytopenias, fatigue, rashes, and some fluid retention. At our center, some of the common side effects experienced include muscle cramps, cytopenias, especially thrombocytopenia, hypopigmentation, nausea, vomiting, and epigastric pain. Management of these side effects is crucial in ensuring adherence to the medication and maximizing quality of life of the patients. At our center, counseling at diagnosis includes discussion of side effects and how they can be managed. Patients are educated on signs and the need for urgent attention, for which they need to stop the TKIs and come to clinic. So they are told some of the signs that need inform them to stop the medication and then come quickly to the clinic. That may include bleeding gums, and that shows that probably your platelets are low, and so you need to come in, stop the drug and come in. They also have an access to phone lines, a phone line, which they can call if the need arises. New patients are seen 2 weeks after they start therapy to assess tolerance, address any concerns, and reinforce counseling. What are some of the challenges? Adherence when side effects occur. It's always very difficult trying to convince someone to take a drug in the midst of side effects. Anxiety, especially during the period the side effect is being managed. Definitely they are anxious. You'd counsel them, let's do this and see if it will improve. And that's sometimes can be tricky. And so we do that as well. Now, not all side effects, can go away. Some you have to live with it, although it may be minimized. And that also becomes a challenge to adherence. So let's look at case 1. We had one Mr. O.A., a 44-year-old male who was referred to our facility in May 2023. The referral followed a 3-day history of diarrhea, during which time a peripheral facility documented hyperleukostasis. So it looks like this was an incidental finding. Now, the peripheral film revealed a leukoerythroblastic picture with complete spectrum of myeloid precursors, and the blast count was 1%. So that's the full blood count at presentation with a hemoglobin of 11.8 grams per deciliter. Total white cell count was 241 times 10 to the power 9. So you can appreciate that there was a lot of white cells in there, and that was the platelets. PCR gave us a transcript level of 46.93. Treatment with imatinib was initiated at 400 milligrams daily. However, a week later, Mr. O.A. began experiencing palpitations, restlessness, nausea, and unusual feelings of warmth and dizziness shortly after taking the medication. Imatinib was temporarily discontinued for 5 days. Following a normal echocardiogram and ECG, the medication was restarted at a reduced dose of 200. This dose was well tolerated and gradually increased to 300 milligrams after 3 days, and then to 400 after another 3 days.
Amma, could I just pause you there and see
Yes.
whether we might bring Valentin in at this point? Is there anything, Valentin, that you have other questions about, or things that you would be thinking differently or might have done differently?
No, not really. So far, she's describing the way that we treat a CML patient in most center. I guess the only question that I have is that is regarding the time that you think that patient are, how much time it takes in patient probably are suffering from CML until they are diagnosed. What I mean that here it's quite frequent that we see CML patient in a very early stage, because it's quite frequent that, in our countries, everyone takes a blood test at least once a year. So, and you mentioned that cytopenia is a quite frequent problem, and we know that commonly happens more frequent when the patient are diagnosed in an earliest stage of the disease. So do you commonly find, I mean, since the population that you commonly diagnose are quite young, the question is it very frequent that you found a patient with very high count of leukocyte and a large spleen, which could be related to, I mean, to later, later time of diagnosis?
Unfortunately, yes, but I must say that over the years, the awareness has been created and we're seeing less of these advanced cases. But yes, unfortunately, we do see patients who come in late, so maybe late chronic, yeah. And then we also don't have that doing checkups, we only seek help when we are in trouble, so to speak, in terms of health. And so we are also trying to advocate that at least once or twice a year, people just do a general checkup so that some of these things can be picked up. So it's something that is in progress, something that we are all harping on so that we can detect some of these things early. But I must say things have improved in the last few years.
All right, that's good.
Right.
So, and regarding this specific case, I mean, we see that, I mean, the patient is not in an optimal response after 3 months, probably to dose interaction and decrease the dose. And now is in quite a good optimal response. How long did it take to get to this 0.04? Because it was diagnosed in 2023, you mentioned, so this is the result after 1 year and a half, something like that, right? Which is quite a good response.
Yes, this is quite unusual in terms of the side effects, and then we actually had to even go down to 200, which we normally don't do. By and large, in terms of hematological response, for those who respond to imatinib, within 6 weeks to 2 months, you have hematological response, big spleens all kind of disappear. And so with this patient, and when they have the opportunity, we encourage 3 months and then 6 months to do the BCR ABL. And I must say that for those who respond and they don't have any side effects, by 6 months, they definitely are less than 10%.
Okay.
So we're getting good responses
Yeah.
here.
Yeah.
So the patient achieved hematological response despite the dose reduction and the temporary stopping of the TKI. Went back to 300 milligrams, and we did the BCR ABL. It had reduced to 18.71%, and the current one, which is just last week, the patient is now 0.047%. So this is the first case, highlighting some of the bumpy stats that some patients go through when it comes to TKI, and the success story with some of the interventions that we do. Thank you.
Okay.
Super.
So that's the first case, yeah.
We've just got a hand up. Augustine, would you like to come in and ask your question?
Yeah, I think that there was a question after how long did it reach the 0.047 since starting the imatinib?
Yeah, I think Valentin had also asked that question, which was in the chat but maybe you could just clarify again, Amma, how long did the patient take to reach the response level of 0.047% at the reduced dose of 300 milligrams?
So this patient started in May 2023, and so he's done about 1.5 years. He's done about 1.5 years. Unfortunately, we don't always have the opportunity to do at least 3 monthly PCRs. So it's been a bit difficult trying to see what the progress is. But the last one was done just last week. The patient happened to come in last week and we have kits. And so we did it as well. Yeah.
That's
Okay.
great.
Yeah,
Super.
so I have another question, if I may. So the main issue with this patient was the palpitation and the heart. So, and I guess, I mean, it was you think that it was related to the medication, because once the treatment was interrupted, or even you decreased the dose, those side effects improved, right?
Yes, it's improved.
Yeah.
And the interesting thing is that, as I said, every individual reacts differently,
Yeah.
to these drugs. Yes. So this is one, I hadn't come across anything like that, and we had to be bold and try and navigate through it. And fortunately, we have been successful with it so far.
Yeah, I mean, that will be an adverse event that will probably worry more, in case that the patient would have started with, for example, with nilotinib, because we have to worry about cardiovascular event and ischemic heart disease, even though the patient is quite young, without relevant cardiovascular events. But it is important. I mean, it's not so frequent, but I mean, all TKIs may be related to some heart side effects. And I mean, as you did, it is very important to perform an electrocardiogram and see that everything is okay, not only to avoid ischemic disease, but also a prolongation of the QT. And it's very important also to check some other medication that could have some interaction with the drug that we use, and increase the QT. But it's quite interesting, because it's not so frequent that the patient will suffer from palpitation. Maybe it was also the anemia that improved after the treatment, and the reason why the side effects improve. So the question that I have also for you is that in this patient is achieving a nice optimal response. So in case that this patient will maintain a deep molecular response during next year, for like 3, 4, or 5 years, is it also in your practice that you plan to interrupt the treatment as a TFR strategy?
Well, because of the bumpy stats, he won't be my likely candidate unless, things really change. And with time, I might go for the optimum dose again of 400 and see how things go. And if he's able to tolerate that, or if he gets into a deeper remission with 300, yes, why not? But he wouldn't be my first candidate for TFR because of the bumpy stat and the dose reduction.
That's great. Thank you, Amma. Let's move on to your next case. I can see that Becky has her hand up for a question, but we'll have time for a wider discussion after your second question as well. So Becky, keep hold of your question and come back with that after Amma's brought her second case, just so we can keep to time. And Amma, could you speak a little closer to the microphone, just to make sure that particularly our interpreters are able to pick you up. Yeah, jump in with your second case, and then we will come back to some of the questions for the first case as well, and the second case after that.
Thank you. Is my sound better? Hello.
I can hear you. I will wait to see from the interpreters, but yeah, as loud as possible, please.
All right, I'll manage that. So the second case is a 39-year-old female diagnosed in February 2009. Full blood count at presentation had an anemia, 8 grams per deciliter, a total white cell count of 136.5 times 10 to the power 9, and platelets of 982 times 10 to the power 9. And the initial BCR ABL was 16%. So she started Gleevec in May 2009 at a dose of 400. And 2 weeks later, after starting Glivec, the patient started complaining of weakness, feeling drowsy, muscle aches, and nausea. The dose of Glivec was reduced to 300 milligrams daily, and this minimized the symptoms. Patient was encouraged to take tonic water to help with the muscle cramps. We also did a serum calcium, and that was normal. Then patient was also counseled to eat well before taking the drug to minimize the GIT symptoms. In June 2011, Glivec was increased to 400 milligrams. The patient remained on the same dose with occasional complaints of muscle cramps till September 2019, when the symptoms resolved. The patient is currently on Glivec 400 milligrams daily and is doing well. And the latest BCR, which was done a year ago, is 0.0030%. And he's coming in next month and would have one done as well. But he's doing fine and has no complaints. Thank you.
Thank you, Amma. Any immediate response from yourself, Valentin, on this case? Anything that is surprising to you or?
No, I
different?
mean this case is quite a common case that we see in the clinical practice. I mean the adverse events that you mentioned are probably the most frequent ones when patients are treated with imatinib, and some myalgias and muscle cramps are quite common, especially for patients treated with imatinib. In this case, it's important also to see whether, I mean, there is the calcium and all the electrolytes are okay, and it's important to manage those in case that we have an optimal response, and also to tell the patient that these side effects can only improve, as happened with your patient with sometimes. However, it is true that, I mean, these side effects sometimes does not improve after time. It's not so frequent, but sometimes, I mean, it's the reason why we could even think, in case of we have opportunity to change to another TKI that could be related to less probability of these specific side effects. Now, I mean, in case that the side effects remain, now that the patient is in an optimal response after more than 5 or 6 years, I mean, something that you can do again is to reduce the dose, because what you need at this moment is to improve the quality of life, just maintaining the nice response that the patient have. But as you mentioned, the patient is doing pretty well at this moment.
Thank you very much. I must say that the muscle cramps is something that is of concern, you know, to the patients. You know, some have it, the aches in their neck, and I've seen a patient actually have a muscle pull or a cramp, you know, and it's tough. It's tough, and so I picked this thing to kind of highlight it. And to say that, yes, sometimes it gets resolved, but sometimes it doesn't, and patients have to live with it.
Yeah, absolutely. And this is a side effect that, I mean, maybe for 1-2 months, it's some other treatment for some other hematological malignancy is not a big deal. But if the patient has to take the medication for a long time, this is what we commonly see: low-grade side effect but as you mentioned, with an important impact in the quality of life. So it's very important that we manage the patient in the best way, because we want to cure the patient, but we also want to have them with the best quality of life. And after time and after an optimal management of the patient, sometimes, I don't know what you, Gianantonio, think, that sometimes this may be also a reason, as I mentioned, if possible, to change or at least to think in treatment change in order to improve this side effect.
Thank you very much.
There's a question in the chat, Amma, from Alam. How frequent is thrombocytopenia in your patient population? And how successful is dose adjustment in solving that while balancing treatment responses?
Of all the cytopenias, it's thrombocytopenia that is most prevalent. Probably if you have 10 patients, I can say maybe about 4 to 5 would have some thrombocytopenia. Especially after 2 months of treatment, you start seeing that. And it's always a balancing act, really, in terms of reducing the dose. It gets better, and then after some time, you increase it again. For some, when you increase, things are stabilized. For others, platelets drop again, and then you kind of maintain at 300. But then if they have the opportunity to do the BCR, then we know how they're doing in terms of molecular remission. I must say that so far, getting molecular remission, at least major, 0.1% has been good so far. But it is difficult, and it is a balancing act. Thank you.
Great. Thank you, Amma. Is it Fatu? Would you like to come in? You have your hand up. Come off mute and ask your question.
Thank you very much. May I speak in French, please? In French?
Just wait to hear from the interpreters if we can do that. Can we have? Yes, we can. Yes, go ahead.
D'accord. Merci beaucoup pour la belle présentation. Je peux dire qu'ici au Sénégal, on a exactement les mêmes effets secondaires, en sachant que, en général, ce qui nous aide, c'est de changer la manière de prendre les doses des ITK. C'est-à-dire, au lieu de le prendre à jeun avec un grand verre d'eau, beaucoup de patients ne supportent pas. Et on est arrivé des fois à leur demander de prendre cela au milieu du repas ou à distance, après avoir bien mangé. Et c'est comme ça qu'on est parvenu à changer la mode de prise pour éviter les effets secondaires qui peuvent être digestifs, qui peuvent entraîner des nausées, des vomissements, etc. C'est pour ça que je voulais intervenir pour dire qu'on peut essayer quand même de prendre les médicaments, le Glivec par exemple, à distance des repas. C'est-à-dire on mange d'abord et puis après on prend. Maintenant, ma deuxième contribution, c'était par rapport au premier cas que nous venons d'entendre. Pour le premier cas, il nous est arrivé également de changer carrément d'ITK. Et cela nous a permis d'avoir moins d'effets secondaires. On est passé, par exemple, du Glivec au Spricel et les malades ont pu supporter le Spricel parce qu'ayant moins d'effets secondaires. Merci beaucoup.
Thank you, Fatou. Alexandra, are you able to? I only got that in French, so it might be just me. Or Alexandra, are you able to give us a summary of that question in English for Amma to respond to? I can't hear you, Alexandra. No. Use the interpretation button.
I managed to do that.
Amma had it. Great. Okay.
Yeah, I managed
Go for it.
Okay. Please, can you hear me?
I can hear you, Amma.
Okay.
Yeah. So
All
you
right.
go
Okay.
ahead. If you can just give a quick overview of the question for
Yes.
anybody like me who didn't do that. And
I know.
Anna,
I didn't catch everything, but maybe Alexandra.
I can try to speak English if you want.
Okay. So I think that just was the first thing was a comment saying that eating well before taking the drug minimizes the GIT side effects, and that they encourage patients to take their medication after they've eaten. And I think that's a good thing. I think I talked about it. It's only that when it comes to nilotinib, for example, when they do take in their meals, they have to wait an hour or two before they take their medication. So we try and tell them, you know, for nilotinib, either you take it before you eat with an interval or after. So we try and encourage our patients to eat and then have an hour or two before taking the medication. And then there was also a comment on the first case. And with the first case, what they did, I think they had a similar case. What they did was to change to dasatinib, and they found out that it was more tolerated, and the patient is doing well. So that's what I got from there. Eating well and then change of therapy. Thank you.
That's fantastic. Thank you
that's,
for that.
Those are important things that we might discuss with the patient. I think especially for gastrointestinal tolerability, I mean that is a good advice to eat before. And also there are something that sometimes works for some patients is that they take the medication right before they go to sleep, because if the side effects are low, that won't wake them up. I mean, they will have the side effect while they are sleeping, and sometimes I mean they do better. So this is a chronic medication. So we can try to try different strategies for each patient in order to improve the quality of life. And these are some advices that we can always do. Absolutely.
Great, thanks, Valentin. So I know that before we had a question maybe from Becky and from Ivy. So if you would like to ask your question, please feel free to jump in. And I'm also wondering whether Gianantonio, if you had any response to Amma's cases, as we have some time for discussion as well.
So, yes, Amanda, a general comment. First of all, I saw that both patients from Amma had problems, particularly during the first 2 weeks. They are young patients, and the problem there is larger. So I suggest eventually a run-in dose is not per prescriptional suggestion, but starting imatinib 200 milligrams for a few days and going up to 300 after another 3-4 days and reaching the so-called ideal dose to 400 in 2 weeks. And this sometimes reduce the impact. The honeymoon with the drug sometimes is difficult to be managed. And I have even a question to Amma. Your last patient had problems with muscle cramps, right? And with 300 milligrams of imatinib, things were doing better. And at a given point, you came back to 400 when the patient, you called it the ideal dose of 400, but at 300, she was already fine, in good response. So I believe that, as Valentin suggested, to adapt the dose to the patient tolerability and response. So that patient at 300 was responding very well, and muscle cramps were less relevant. And so in my experience, I would be happy to remain on 300 of imatinib instead of trying to go, because you know the ideal dose of TKI is yet to be defined for many drugs, and 300 of imatinib when the patient is responsive is that they are okay. That's my experience. So of course we have different experience, and in my clinical life I never found a medication or something different. Even some patients try with tonic water to reduce muscle cramps incidence, but in my life I never found something really efficient to do that. But in your experience, suddenly the patient quit to refer problems of muscle cramps? Reason unknown, but at a given point, everything disappeared. No, yes, it was a. That's why you anticipated, Amma, that every patient is different from the other in the reacting. So it's our ability to adapt the dose to the patient response and tolerability. It was just a comment, but general comment.
Thank you so much. She is one of the lucky few to have it all go away. Yeah. Thank you so much. Thank you.
Yeah, this was running dose is valid for all TKIs. I lived 20 years along with Michele Baccarani, and we both did so in our frontline because, you know, giving 400 milligrams of imatinib suddenly or 600 of nilotinib or whatever has a bad impact with the patient, particularly if young. You know that quality of life with imatinib is clearly and significantly less brilliant in younger patient population with respect to older patient population. And in female, young female worse than in male. But with imatinib, I'm referring to imatinib only.
Okay. Thank
Great.
you.
I think we've got a question from Becky. Do you want to come in, Becky?
Yeah, thank you so much, Dr. Amma, for the presentation and the cases. My question would be on, have you encountered patients who would generally respond very well clinically? So you have got good hematological response. Clinically, they're doing well. Otherwise, they're tolerating, so they do not have adverse events that are making you think about changing the TKI, but your BCR-ABL is not probably very optimum. So you are not getting probably at 0.1 or so by 12 months. But clinically, they're not giving you any other reasons to change to a second generation or otherwise. So for those particular patients, what would you generally do?
So usually I talk about compliance and find out about adherence, you know, especially when they are young, you know. That is what I do initially. If I'm quite satisfied that that has been done, then we'll probably see if we can have the BCR more frequently. But my first thought will be about compliance. Are they really taking the drug or not? And how are they taking it?
Great.
I hope that helps. Yes, thank you.
Becky, anything further from you?
Yeah, my worry was, or rather my concern was, are you very strict at maintaining all your patients at molecular response, at like deep molecular, even when you do not have any other indication of changing your medication and the patient is quite compliant? Because I have seen a few of those patients where your BCR-ABL doesn't seem to be going down to the ranges that are expected, but clinically, hematologically, they're just doing quite all right, yeah.
You know, hematological remission is the last one to go, you know, so they may be in hematological remission, clinically they are fine, but maybe at the molecular level, cytogenetic and molecular remission, things are not too good. So when patient is clinically fine, that's good, but then probably something is happening. So I always tell my patients that it's important to do the BCR as well, so that we actually know what's happening. Because if we're waiting for a reflection in the full blood count, maybe things will be a little late. So that has been my approach.
Yeah, I mean, if I add something, I mean, you're asking, I think, what is the best moment on when we should perform treatment change. And I mean, And the answer is when the patient failed to one drug. And the failure may be related to either to intolerant or what we know about as resistant. You mentioned that a patient that is tolerated well the drug, so is not intolerant, and now we have to focus on resistant. It is true that we all want our patient to achieve the molecular response, but only a few percentage of patients will achieve. So we need to guarantee that as far as we can that the patient will not progress. And we know that will not happen if the patient is something below 1%. That is a clear definition of failure, patient which is above 1%. So if your patient is after 12 months of treatment with a molecular response below 1%, like as you mentioned, 0.5, 0.6, and the patient is doing well in terms of tolerability, that patient still have a chance to improve optimal response further on. And I will continue with the imatinib and see what's going on after 2 or 3 years. It's not really mandatory to change treatment if your patient do not achieve a major molecular response. It's just a warning. You can monitor the patient closely, and especially if the patient is doing well in terms of tolerability, just move on and maintain the treatment. That's what I will do.
Totally agree. Totally agree with Valentin on this point.
Okay, great. Becky, anything just to, yep.
No, thank you. That's very clear. Thank you.
That's wonderful. Thank you. That is all we have time for in discussing these cases. So we're going to move on now to our next set of cases from Ephrem. Thank you so much, Amma, for preparing those and bringing those and for the discussion. And thank you to everybody also who has asked questions.